for tuning in. This is Ryan Smith with TAILOR Compounding, and as we get ready for the holidays, definitely wanted to talk a little bit more about repair and recovery. As we referenced the peptides for repair and recovery, there's a lot of different things we can talk about. One of the biggest things, I should say, biggest categories in the space is repair and recovery. In addition to using things like the stem cells, PRP, exosomes to enhance repair and recovery. There are a lot of different areas we can talk about with this, whether it be recovery from nerve injuries, whether it be ligament and tendon damage, whether it be tissue damage, or even like TBI and stroke. And so before we go any further, I just want to, at the very least, reference some of the ones we won't be going over much, which are going to be, sorry, just real quick. Some of the ones we won't be going over as much, the Strubelison or the Thymosin beta-4 for TBI repair and recovery. After any type of head injury or traumatic brain injury, those have been studied and shown to be really, really effective. Beyond that, we won't be talking a lot about neuropathy, or particularly diabetic or vascular neuropathies, which things like the Thymosin beta-4, IGF-1, the GHK copper can definitely help with. So with that, I definitely want to get into, at least in the very beginning, the ARA-290. The ARA-290 was the subject of one of our last webinars, but unfortunately, there were some troubles with the slides and the recording, so I'd like to go over it one more time. The ARA-290 is a really, really interesting peptide. It's 11 amino acids, meant to, at least originally, to treat neuropathic pain. And neuropathic pain, or pain caused by a lesion of the somatosensory nervous system, has increased slowly over the last few decades. It remains very, very difficult to control this chronic pain condition, and it's usually associated with a large variety of disorders, metabolic disorders or infectious disease, or anything that would affect small afferent sensory nerve fibers. So things like diabetes, sarcoidosis, or leprosy, and also diseases of the central nervous system like stroke, MS, TBI, or spinal cord injuries. These patients usually experience a lot of different symptoms, but usually it's exaggerated pain to different instances which shouldn't precipitate that much pain, or pain when they shouldn't feel pain at all, such as I mentioned here, intolerance to bed sheets. And despite knowing a lot more about this over the past few years, there still aren't a lot of quality modes of treatment, with 30 to 50% of patients still not finding adequate pain relief. And so we definitely want to talk about the ARA-290 and also the pathophysiology of how this type of neuropathy or this neuropathic pain occurs. And traditionally what it is, it's unfortunately an upregulation of the inflammatory nerve response. Inflammation is usually thought to be caused by nerve damage and can actually cause peripheral or central sensitization with hyperalgesia. And that happens whenever these macrophages, or the microglial cells and monocytes from the peripheral blood, sort of go to the spinal cord and sort of invade it, showing areas of hyperreactivity. Here in this figure, you can see a lot of that hyperreactivity in those inflamed glial cells all around the spinal cord. And what we know here is that whenever these inflammatory cells get to the spinal cord, they cause a lot of inflammation, and then that causes a lot of different issues. And we know this we know that this hyperactivity is the issue, and this positive feedback loop is the issue, due to what we've seen with several other drugs, in particular also ketamine. Ketamine is one of those drugs that basically a lot of this microglial activation and actually reverse this mechanical allodynia, which is really, really important. Usually it's upregulated factors such as fractalkine, chemokine, motifs, ligand 2s, tumor necrosis factor, which results in this upregulation of these macrophages and this hyperreactivity, which results in this neuroinflammation and pro-inflammatory positive cascade. And so the ARA-290 can really prevent that upregulation of inflammation. And the reason it does that is because of a different pathway. This pathway is typically usually as a result of mitigating these inflammatory mediators. There's these adjacent anti-inflammatory cells which are upregulated, and one of the most important signals which is upregulated is EPO. And EPO is very, very different as it's secreted in the tissue than whenever it's secreted by the renal system. Tissue EPO is very, very short acting, and instead of just activating these, instead of activating these production of these mature red blood cells, it actually activates the innate repair receptor, this IRR receptor, which is a type 1 cytokine, which causes significant downregulation of this inflammatory response. And it's usually upregulated in response to tissue injury, hypoxia, metabolic stress, and many, many others. And so ARA 290, knowing that what erythropoietin in this tissue does and this paracrine effect, ARA 290 was created to have the same effect on the innate repair receptor without the hemopoietic and thrombotic effects of erythropoietin. And so they designed this ARA 290 molecule to be 11 amino acids and specifically work on that receptor. And the results have been absolutely fantastic. Here, I talk a little bit about the pharmacokinetics of the ARA 290, showing a half-life of 20 minutes with subcutaneous injection and just 2 minutes of half-life after intravenous injection. Most of the trials we'll talk about in human studies have been done with subcutaneous injections alone, and that this ARA 290 in animal trials does activate the central nervous system and crosses the blood-brain barrier as well. Whenever we look at ARA 290 in terms of who do we use this for, a lot of it is going to be neuropathic pain, but this could be with anyone who has experienced any type of injury of the central nervous system or peripheral nervous system. Here we see improved sensory nerve function in induced diabetic neuropathy. We see reduced pain and increased motor function in rodents after L5 spinal nerve transections, after dorsal root ganglion crush injuries, and constriction injuries as well. And what we see are signs of spinal inflammation were highly reduced, resulting in less active glial cells and decreased release of TNF alpha, interleukin 1 beta, and NF kappa beta in the spinal cord and other sites all around the body. And so in addition to this, it's also shown to promote the repair of autonomic nerve fibers, sympathetic ganglia, in mouse models of diabetic neuropathy. Here is a study showing the effective treatment and pain in animals versus control, which obviously shows really, really good results for pain. So for anyone who's had any type of central or peripheral nerve injury, the ARA 290 is definitely something to consider. Here we also see that it inhibits capsaicin-invoked TRPV1 channels in the dorsal root ganglion and trigeminal ganglion cells. And this is important because it basically just shows again that it can modulate the neuroinflammation to actually increase repair and proliferate nerves in healing. It has a lot of human clinical results as well. This in particular was looking at small fiber neuropathy and signs of automatic nerve fiber loss, where they received ARA 290 as injections, 2 milligrams on Monday, Wednesday, Friday. And here we saw pain relief was maximal in the third, with a 25% reduction in pain in patients with type 2 diabetes and a 40% reduction in pain with people with sarcoidosis. So again, this is helping with those small afferent sensory nerve fibers and shows significant reductions of pain. And this other trial looking at small fiber neuropathy, it's a phase 2 clinical trial, showed that actually we're able to see rapid regrowth of small nerve fibers in the cornea, which obviously is a sign of tissue healing and restorations as observed in some of these other previous studies. And beyond that, these patients all exhibited functional benefits, such as the ability to walk for longer durations without pain. And in fact, 50% of patients receiving ARA 290 could walk at least 25 minutes more, compared to only 12% in placebo-treated patients. So again, this has had some really, really good results. In addition to its results on just nerves, it also has a benefit of reducing inflammation all over the body. And this can present benefits in a lot of different disease states. For instance, in systemic lupus, we see reduction of inflammation and therefore a lot of better outcomes. We see that it can additionally prevent cardiac decline, and it can help heal burns as well. And then beyond all of that, it can even have an effect on metabolic control, where we see the cholesterol to HDL ratio and high density lipoprotein ratios look a lot better, as well as a pretty severe decrease in HbA1c in just 42 days, being very, very significant as well. And the other big thing about the ARA 290 is you don't need to do it for very long. 5 to 6 week courses have shown lasting benefits of up to 2 years of pain-free. So even a short course, a really, really good effect for the lifespan of your patient. And this is now currently in phase 3 clinical trials and is probably on site to be an FDA drug within the next FDA approved drug within the next 2 years. And so with that going on, I also want to talk about another new product of ours called the 5-amino-1-MQ. I've spoken a lot about the 5-amino-1-MQ lately as it relates to the NAD salvage pathway. The 5-amino-1-MQ inhibits an enzyme called NMNT. And this enzyme is usually upregulated as we age, particularly in white adipose tissue and in muscle tissue. And so usually this can shunt the precursors to NAD out of the NAD salvage pathway and therefore reduce energy metabolism, reduce SIRT1 activation, among a lot of other effects. And so this was originally studied for weight loss, and still it's pretty highly effective at weight loss. In mice trials, it showed a 70% reduction in lipogenesis. And mice who have this enzyme inhibited through other means can actually show are protected from diet-induced obesity and show reduced adiposity. So this is a great way to prevent fat accumulation. But really the one reason I want to look at it is not for this reason. Here I go in more into the effect of it has on weight loss, but I want to talk mostly about its effect on muscle stem cells. This is one of those really, really interesting results, which we weren't expecting when we first rolled it out. Focusing almost entirely on the NAD salvage pathway was our focus for increased metabolism and body composition, as well as longevity. In addition to that, it also has an effect on muscle stem cells. Muscle stem cells that proliferate and then differentiate into competent myoblasts are really, really important in muscle regeneration. And as we get older, these fusion competent myoblasts decrease and more of them go into a senescent state. We've talked a lot about senescence before and how reducing that senolytic burden can really help, but changing things from a senescent cell back to a quiescent cell is relatively difficult. However, the 5-amino-MQ seems to do exactly that, and it seems to activate these senescent muscle stem cells, resulting in the ability to help promote and repair and recovery in these cells. Some of the results from this particular study in mice showed that muscle stem cell proliferation and fusion were elevated in these mice, supporting nearly twofold greater cross-sectional area in these muscle fibers after injury. Beyond that, we also saw an increase in contractile force by almost 70% with these NMN inhibitor treated mice. And so this presents two really amazing findings. One is that we're actually increasing the cross-sectional fiber area of muscle, and then secondarily, we're also increasing the contractile force. And so this is something to definitely think about in repair and recovery for anyone undergoing a procedure as they get older. So particularly if they're, anyone over 60 who has a high burden of senescent cells, is something to think about. Another thing I want to reference is that while this has only been studied for muscle stem cells, we also know that one of the biggest pain syndromes in elderly people with osteoarthritis, and osteoarthritis is one of those diseases which is extremely highly correlated with senescent cells. And so osteoarthritis might also see a benefit in older patients for this product as well. Before I go on, just want to reference that this is usually done at 100 milligrams to 150 milligrams daily, and this is an oral capsule that should be taken with food. And so definitely something else to think about if you're recovering from injury. One of the ones that we've really stepped up in terms of the amount that we're doing recently is called pentazan polysulfate as well. Pentazan polysulfate is an anti-inflammatory marker that's actually FDA approved and has been approved as an oral drug for interstitial cystitis. However, recently there's been a lot of developments in terms of using this for different indications, and particularly, as I mentioned earlier, osteoarthritis. The pentazan polysulfate is extremely anti-inflammatory and has pro-chondrogenic properties, and this has been in the horse industry for even longer than it has been to treat osteoarthritis in the human model. However, this graph I listed on the right is from Paradigm Biopharma, who released a trial in January of 2019 showing significant increases in reduction of pain in osteoarthritis. And this is actually done, as I mentioned here, induced proliferation and chondrogenesis of mesenchymal progenitor cells in vitro and in vivo. And however, the effect of pentazan sulfate still remains unknown for osteoarthritis. Obviously, we know it has a really, really good anti-inflammatory effect, and we believe that that's part of the reason we see the reduction of pain. Usually, this is dosed at 2 milligrams per kilogram twice weekly, and it can be used in a variety of repair and recovery patients, but osteoarthritis by far has the most data. The study I referenced earlier, this phase 2B in Australia by Paradigm Biopharma, which showed the really good results for osteoarthritis. However, beyond osteoarthritis, it also has other conditions, particularly apologize for the slide not coming up, but it also has effect in any type of spinal disc compression or back pain. The anti-inflammatory effect is not limited to osteoarthritis in the knees and would be something else I would highly recommend. For these next couple of things, I'm going to go very, very, very quickly. These are ones that we always recommend for a variety of conditions, but sort of constitute the basis and sort of the first line treatments that most people use for any type of perioperative recovery or any just sort of first step recovery. And those tend to be the growth hormone secretagogues. In addition to repair and recovery, growth hormone obviously has a lot of other benefits. It acts on muscle, fat, and other tissue to encourage growth. It increases lean muscle mass, decreases fat mass, lowers risk of cardiovascular events by decreasing C-reactive protein, reducing carotid intima media thickness, reducing triglycerides, and it improves energy and cognition. So it has a lot of other effects, but it also has a lot of effects as it relates to nerve regeneration and muscle reinnervation. So again, for anyone who has any type of injury that has to do with the nerves, the growth hormone is also something to consider. And here's another paper that obviously shows that it can help in patients with recovery spinal damage. There are a couple studies, particularly one in 2013, which show that growth hormone shouldn't be used in all types of injury and in any type of repair and recovery, particularly for tendon to bone rehealing. It can actually be a little bit detrimental. It didn't show any increased timeline for joining that tendon to bone, and actually showed a reduction of strength in the bone post-recovery as well. So not something to be used in all injuries, but definitely as it relates to any type of nerve and muscle deinnervation. Going real quickly, our growth hormone protocol, there are really about 4 products we frequently use for growth hormone secretion, not counting growth hormone itself. The Sermorelin combo has been used forever. The CJC combo with Ipamorelin is by far probably our most widely prescribed. And then the Tesamorelin has a particular benefit for repair and recovery above all the others because it has a massive increase in IGF-1, with the average benefit being 181 points. And that is significant, as IGF-1 can be the main downstream intermediary for repair and recovery. So hormone secretagogues are always something to think about, and would redirect you to email me at rs@tailormadecompounding.com for any further information on these products. This goes a little bit into more mechanism of action and how each of these products are affecting their secretion from the pituitary. This goes a little bit into Tesamorelin and some of the benefits in particular, and some of the protocol options. I also want to go real quickly into the BPC 157. The BPC 157 is one of those which has no published, but several human clinical trials for up to phase 3 for ulcerative colitis, but has no published human trials, and is great. Well, we've seen this for just about every type of repair recovery, and it has studies to mimic that in animal models as well. This originally is composed of 15 amino acid sequences and derived from the human gastric juice. It's naturally produced in the GI tract, so it's enzymatically stable. It's bioavailable. It gets very, very pleiotropic with many, many different mechanisms of action, and as I mentioned, orally. In addition to its effect on a lot of tissues, it's also incredibly anti-inflammatory. It can decrease myeloperoxidase, leukotrienes. It is neuroprotective in the fact that it modulates the serotonergic and dopaminergic system and can help protect in TBI. It can regulate gene expression, such as increasing nitric oxide and VEGF, which promotes angiogenesis and vasculogenesis. And then it also has effects on repair tissues such as tendon, ligament, brain, and bone. This goes into more of the injuries, but I also want to talk about how it particularly helps tendons and ligaments. What we know is that this increases type 1 collagen and it can be effective as little as 10 micrograms per kilogram. And again, orally can be done as well with up to 500 micrograms per day being used. This goes into a bit more of the effects on tendons and ligaments, also referencing the fact that when you growth hormone, it can actually increase those growth hormone receptors on tendon fibroblasts. And when they're activated, these fibroblasts can definitely secrete more of these structural intermediaries like the collagen, like the fibrin, and therefore help with any tendon and ligament injury, from tendonitis to Achilles tendon dissections as well. And again, this just showed that microscopic and macroscopic evaluation showed outcome close to non-injured ligament, meaning that it repaired it almost perfectly. This is obviously in a rat. Granulation of tissue was faster and better organized of collagen, and it was more of that type 1 collagen with less inflammatory cells and more abundant fibrin, which was thicker as well. So the outcomes were definitely better in the mouse model, and we've seen this time and time again in the human model as well. In addition to its effect on tendons and ligaments, we also know that it can help heal bone defects and help recover from breaks or any type of bone injury. Into it with one of the best studies. No evidence for extracortical new bone formation, bony hypertrophy, or ectopic bone formation, and basically just established bone homeostasis in a better way. One of the other ones I mentioned for neuropathy as well as TBI and stroke is the thymosin beta-4. But the thymosin beta-4 is one that has been used in sports doping for the past 20 years to decrease the risk of injury and reduce delayed onset muscle soreness. This is found in all human cells, but naturally in a high concentration in tissue damaged areas. It's one of the first genes upregulated when you get a cut or injury anywhere in your body, particularly in the soft tissue. It is an actin monomer sequestrating protein, so it helps build the cytoskeleton that you need for repair and recovery after injury, and is really also helpful in promoting stem cell differentiation, cell migration, and increasing angiogenesis. It also is extremely anti-inflammatory with decreased inflammatory cytokines across the board, and is actually an FDA-approved drug, which some people don't know. This goes into the different ways which it can promote wound healing, but also act as an anti-inflammatory, and then all the different categories by which we can do both. And so this is really one of the most perfect repair and recovery products we have available in our body, and sometimes supplementing your natural production of this can be very, very effective. As I mentioned earlier, actin is a sequestrating protein which upregulates cell binding proteins such as actin and myosin, and forms of contractile filaments of muscle cells, creating that cytoskeleton which is needed for repair and recovery. And so this shows that it has a regenerative protein, and how it can upregulate stem cells via an IL-8 mechanism and metalloproteinases, particularly MMP2. This also shows how it can reduce oxidative stress by acting as an antioxidant and increasing anti-apoptotic genes in cardiac fibroblasts. So in addition to its ability to act as an anti-inflammatory and building that cytoskeleton for repair, it can also decrease the effects of apoptosis or abnormal apoptosis in certain cells. And so again, thymosin beta-4 can be used for athletic recovery, post-surgery healing and injury, even hair loss, TBI, lung inflammation, corneal healing. This is one of the most diverse products for repair and recovery. And this combined with the BPC should be almost considered as a first-line therapy for any type of repair and recovery. And we see good results even within a week. And so highly, highly recommend the combination of this and the thymosin beta-4 and the BPC. We even compound them together in a month's supply. Generally, the thymosin beta-4 is given at 750 micrograms daily, subcutaneously. You can cycle it. We actually recommend cycling it because it is so angiogenic. We like short courses at high doses. It's even been given up to 1.2 grams IV, and so you don't really have to worry about overdosing it as long as you keep the time periods short. And I also, lastly, in terms of the repair and recovery, want to talk about the GHK copper. The GHK copper is one that's often thought of just for its aesthetic benefit because it increases collagen levels by 70% and reduces fine lines and wrinkles by around 24% in just 4 weeks. But this is a product which is naturally found in the serum, and it decreases significantly as you age. It's about 200 micrograms per ml at age 20, but drops to around 80 micrograms per ml at the age of 60. This was originally isolated from human plasma albumin in 1973 by Lauren Pickard, who is still doing a lot of research on this. And he basically showed that old liver cells could actually function similar to new liver cells with young blood, and thought GHK copper was to be the reason. GHK copper has a lot of different effects: wound healing, anti-inflammatory by decreasing TNF alpha and IL-6. It can help repair irradiated fibroblasts. It can help with nerve regeneration, so much so that it's been shown to regrow myelin in MS patients, and it can recover epidermal stem cells via this anti-senescence marker P63 as well. And so in particular, it also has an effect on orthopedics. This is a study in illustration showing how GHK can help in the different stages of healing for ACL injury, particularly during the cell recruitment and proliferation and granularization phase. This is a 2013 study which looked at ACL repair in mice, and what they saw was that optimizing the direct graft remodeling was thought to be the most efficient method to reduce recovery time. And GHK was able to act as a biological source for copper and copper-dependent enzymes, which cause formation of collagen cross-linking. And so we know GHK can promote bone healing and enhance the attachment of implant to bone, but also can be used as a cell signaler to help cause angiogenesis and cell recruitment. And so that's exactly what we see in these studies. But unfortunately, we saw that a little bit is great, a lot is too much. Here they showed 3 milligrams per ml of GHK actually caused over-cellularity, which actually weakened the connection from tendon to bone. And so for this, we usually say GHK is definitely something to think about for repair and recovery, but don't overdo it. Usually, enough using the GHK as topical cream to face for cosmetic purposes is enough to also help with repair and recovery. And one of the other big benefits of this is it also significantly can reduce scar formation. So especially if you're treating someone perioperatively or postoperatively, this is a good one to add as well, and can be used in combination with thymosin beta-4, BPC, growth hormone secretagogues, or the AR290 or the Pentastan. All of these can work together and don't have drug-to-drug interaction. And then I appreciate everyone joining so close to Christmas. Before we close out the webinar, I just real briefly want to go into two products of 2020 that we're starting to roll out. One is the NAD Electrophoresis patch, or ionophoresis patch. This is another mechanism to level, which is neither, CD38, those PARPs, sirtuins, and NAD therapy is very, very common, but now you can actually do it in a non-sterile format. This right here is an active patch, which uses an electrical gradient to drive NAD across the skin into the bloodstream. This is usually delivered at 400 milligrams per ml on a 2 ml reservoir, so a total of 800 milligrams delivered in a 4-hour time span. And it has essentially what some people who have taken blood shown increased NAD levels. And this has a similar but much lower side effect profile of intravenous NAD for anyone who's done those. We'll be launching this in a big way starting on January 2nd. And if anyone would like any more information, I'd urge them to reach out. One of the other big products we'll talk about, especially in the repair and recovery, is Epicatechin. Epicatechin is usually a polyphenol, which is found in green tea and chocolate. But we also wanted to bring it up because it has a significant effect on myostatin and follistatin ratios. This particular trial looked at an 8-week resistance training and Epicatechin supplementation program and showed significant increases in lean muscle mass when Epicatechin was combined with resistance training. In this study, another study on Epicatechin as well, we saw that all the markers which are decreased as we age, particularly of myostatin and the beta-galactosidase, which is a marker of senescence, significantly decreased with treatment of Epicatechin. And actually, treatment of Epicatechin orally for just 7 days yielded an increase in hand strength of around 70%, and a significant increase in the ratio of plasma follistatin to myostatin levels. So this is another way to help add lean muscle mass for most patients. It's very, very inexpensive as well. But beyond that, it can also help with repair and recovery of muscle fibers as you begin to remodel muscle. So things like the 5-amino-1 MQ and the epicatechin can cause some really good changes in body comp while keeping on that lean muscle mass. So I just wanted to mention those two briefly as we continue to wrap up this webinar. That's been 30 minutes for me, so I appreciate everyone joining in on this particular webinar. I hope everyone has a wonderful holiday and Christmas. Thanks so much, and look forward to talking again soon.